Hi, my name's Tori and I'll be working on the Unit 4 case studies. So I'll first read the question and give you my answer. So the first one that I did was case study 1. A newborn girl appeared normal at birth, but within 24 hours she developed lethargy, hypothermia, and apnea. The attending physician suspects a metabolic disorder and orders a panel of labs. Which diagnostic would be the best to distinguish between a urea cycle disorder and a disorder in beta oxidation? The suggestions that we were given, the answers are blood glucose, urinary acids, serum fatty acids, or plasma glutamine. A full blood workup was ordered for this female and the data is presented below. The initial blood ammonia level was elevated at 314 and rapidly rose to 600. The urine orotic acid level was markedly elevated at 473. And then the plasma citrulline level was normal at 10. In this patient, where orotic levels are elevated, list one urea cycle enzyme that is most likely deficient and one urea cycle enzyme that is least likely to be impaired. So for the first one, for me, the best diagnostic tool to distinguish between a urea cycle disorder and a beta oxidation disorder with the beta oxidation would be the plasma glutamine. The amino acid glutamine is involved in the process of detoxifying and transporting ammonia. So when there's a certain amount of glutamate and ammonia, glutamine synthetase is an enzyme that causes the two to react, and the glutamate turns into glutamine. This enables transport of nitrogen, carbon, and other energy. Nitrogen cannot travel without being, without changing and being basically like a little carried out. So glutamine synthetase also helps to detoxify ammonia. So for urea cycle disorders, the defects are from dysfunctions in the enzymes like glutamine synthetase, and they're responsible for degradation of protein. So ammonia is normally removed by the liver and converted into urea because too much ammonia isn't good for the body. However, in the urea cycle disorders, the ammonia begins to actually accumulate due to some issues with the enzymes, and arginine levels and glutamine levels rise as a result. For beta oxygen disorders, there's some fatty acid transport defect or fatty acid oxygen pathway enzyme defect. So beta oxidation occurs when the fatty acid molecules are broken down into acetyl-CoA and NADH and FADH2. The acetyl-CoA is directed into the citric acid cycle, and the NADH and FADH are utilized in the electron transport chain. They are broken down so that they can provide the body with energy. In low carbohydrate intake, hypoglycemia is usually found in those with fatty acid oxidation disorders. So hypoglycemia is low blood glucose. This is due to the glucose leaving the liver being reduced, and the glucose that's leaving the liver is reduced that level, and the glucose being utilized by the peripheral tissues is enhanced. So there's more glucose in the tissues and less in the blood plasma. So the best diagnostic tool, like I said, for me would be the plasma glutamine, because the levels of glutamine would be high in the urea cycle disorder and would be normal in the fatty acid disorder. So the glutamine has a really large role in the urea cycle disorder pathway. So blood glucose would not be a good test because the urea cycle does not play a direct role in affecting the blood glucose concentrations. So, like I said, it does affect the beta oxidation, but does it affect the urea cycle ones? We're kind of trying to find a common ground between them. So the urea cycle is focused on the nitrogen transport and removal to avoid toxicity. Urinic acids would not be a good tool because beta oxidation does not affect ketones, thus it would not show any signs of disorder in this pathway. Like I said, ammonia then becomes, urea and excreted from the body. Beta oxidation doesn't deal with that directly. Beta oxidation breaks down fatty acids, so looking at the total levels of fatty acids could tell us about our beta oxidation pathway, but not really too much actually about the urea cycle disorders. So the most common urea disorder would be called the ornithine transcarbamylase deficiency. This occurs when the carbamoyl phosphate accumulates in the mitochondria. And like I said, overaccumulation of anything is super bad. So when there's an overaccumulation of this, it gets directed into pyrimidine synthesis. And that increases the urinal orotic acid, which we talked about that she has. So the deficient enzyme would be ornithine transcarbamylase. Ammonia is converted into carbamoyl phosphate. When carbamoyl phosphate accumulates, it is redirected into the pyrimidine synthesis pathway that I talked about, which produces orotic acid. So, however, it is not affected by orotic acid directly. Carbamoyl phosphate, it leads to the orotic acid, but it's not affected directly by it. Ammonia is the precursor to the carbamoyl phosphate. Thus, elevated ammonia could affect carbamoyl phosphate. Carbamoyl phosphate synthetase 1 is the enzyme that converts an ammonium into carbamoyl phosphate. It is not affected by orotic acid levels. Thus, it is the least likely to be impaired by elevated orotic acid levels. So, here are my answers. The one least likely to be impaired by the orotic acid levels would be the carbamoyl phosphatase synthetase 1. And then the one that is most likely to be impaired would be the ornithine transcarbamylase. Okay, so the next question, and I provided the works cited below on my paper. So the next case study that I worked on is case 3. So a 47-year-old man presents with severe pain in his right great toe. He is unable to bear weight on his right foot and there was no apparent trauma. He reports the pain started last night and continued to increase in severity. Based on his physical exam and laboratory findings, he is diagnosed with gout. Gout can be caused by several different mechanisms and blood samples are drawn and urinalysis is performed. The results from this individual are listed below. What is the best explanation for the presentation of gout in this individual? And please explain why the other choices are not consistent with the data or what additional information you may need to decide the root cause. 1, overproduction of purines, 2, decreased salvage of purines, and 3, decreased urinary excretion of uric acid. After further discussion with the patient, he tells you that he recently switched from diet soda to regular soda because he read that fake sugar diet soda was bad for him. He tells you he drinks between 4 and 5 liters of soda a day. Note, the primary sugar in most sodas is fructose or high fructose corn syrup. What is the potential impact of this dietary modification on the presence of gout? So, gout is a type of arthritis that results in joint pain, inflammation, and stiffness. This is caused by an excess amount of uric acid in the blood. The large amount of uric acid causes monosodium urate to form acidic crystals in the joint. So there's so much of it, it's not being taken out fast enough that it starts to crystallize inside the blood, which obviously can be very painful. Is largely seen, like a lot of times it's very much seen in the big toe. Uric acid is the last product formed in the purine nucleotide metabolic pathway. So purines are found in the DNA and RNA as nucleotide bases and other biomolecules. They can be salvaged to use again for new nucleotides. The salvage pathway is when nucleotides are made by intermediates from the degradation of other nucleotides. So it's almost like recycling and reusing. The salvage pathway, basically the salvage pathway is for recycling, like I said, bases, nucleosides from the degradation pathway, using it to make new ones. Uric acid results from the breakdown of the previously mentioned purines. So the purines are made, they break down, they form uric acid. Uric acid is most commonly excreted out through the body so that it doesn't, our body doesn't have a large amount of acidity. It's basically kind of keeping that pH balanced. The presence of high urate shows us that there is gout. So he has high urate, and that means that there is a high acidity, obviously. And the fact that the symptoms happen suddenly were focused in the joint with inflammation, pain, and the infected area was the toe, which we know a lot of times is pointing to gout. We assume that it's a pretty strong indication that he does have gout. When there is an excess of urate, the kidney is unable to filter it and the uric acid builds up, leading to gout. So basically, if you have too much of one thing, and I like to think of it as like a factory, going down the machines. If you have too much of one thing and this one's trying to keep up, but there's a way too much overaccumulation, this part of the machinery, can't do this fast enough, so there's everything overflowing. I think I saw it in an I Love Lucy episode, and you've seen it on a lot of TV. But you have so much coming on, on the beltway, the little belt, and then this one's over, it's trying to work hard, it's working hard, but it just keeps overaccumulating, it keeps building up, and it can never keep up, it can never pass up. So it starts to build up here and starts to cause problems all the way from the beginning of the system. So when we have these high levels or overproduction of purines, they can lead to a high level of uric acid that begins to accumulate in the blood, like I said, as crystallized particles. So basically one of the things we need to know is, is there an overproduction? There is, my big thing is there's a decreased salvage of purines, meaning there is less hypoxanthine and guanine. Without those, the de novo pathway begins, and the purine is overproduced here, leading to high uric acid production, thus gout. So basically, this beltway can be, affected at many different levels, if we're gonna keep with that example. So basically, if we're gonna have an overproduction of these purines, it's gonna build up. All of that uric acid doesn't completely get, excreted out, it doesn't completely degrade enough to get excreted out of the body, so what's going to build up is these urate crystallized products, which obviously we're noticing he's got a high level of urate in the body, so that's going to be the proof that we have it. Now, some of the other answers that were there was, where is it? Decreased salvage of proteins. So like I said, there would be a decreased salvage of purines, meaning there is less of those hyperxanthine and guanine, which if there's no salvaging of purines, it tends to lead to the de novo pathway, which these kind of happen simultaneously. And de novo pathway basically takes it and it's going to continue to produce even more purines, which leads to even more overproduction, which leads to even more, acidity to it. So basically, we need to know that's going to lead to more overproduction and going to lead to gout, obviously, because there's no way to excrete all this out fast enough to get it out of the body. And then answering the second question, the artificial sugar produces more uric acid than natural sugar. So the regular soda is fructose, thus increasing uric acid. This means that the uric acid level should go up in the patient. I agree. I also added the works cited there at the bottom, and I hope you had an interesting case study with me. Thank you.